Uh,
Thank you, Richa.
I'm handing over the screen to you to take it further now.
Yeah, please share the screen. Thank you so much. Thank you so much. So good afternoon, each and everyone. I'm so happy that Tuesday Tea Time is taking a very good promotion, as well as people like to listen it. And this is Learn Simply with the Kawita Bapat, a platform for conversation, insight, and a knowledge sharing. And so many take work messages and a crisp knowledge about the various subjects through the conversation with leaders and experts in the respective field. And the most important point is our goal is to provide practicing OBGYN to access the valuable information and knowledge that can help them to grow professionally and personally. Today, I'm really proud and privileged that I have an amazing person today with us, Dr. Pankaj Desai. We know his extensive experience as academician, teacher, motivator, inspiring public speaker is commendable, I'm telling you. He has made a significant contribution into the medical community to the roles as a consultant OBGYN, dean, associate professor, and unit head at the Medical College, Baroda. Sir, your accomplishments and accolades reflect how much dedicated and how much expertise in the field. You have won the 7 gold medals, OBGYN, exceptional performance in the knowledge in the area. Additionally, delivering 61 orations, giving 771 guest lectures, and moderating and practicing on various panels. And receiving a similar academic honors demonstrate that your active involvement in disseminating knowledge and engaging with academic community. And so the publication record of 107 papers and research papers have awarded being 9, and it exemplifies that your commitment to the advancing scientific knowledge in the OBGYN. Furthermore, the most important part is you have authored 13 books, and your contributions to the 45 chapters in different textbooks illustrates your significant contribution. And notably, you have the international recognition as a visiting professor and a fellow to the Liverpool Hospital, Sydney, Australia, and receiving Young Gynecologist Award by Falk in Bangkok in 1991. Again, the Tamaskar Award for the best infertility work, awarded by the ICOG 2003. But the most important contribution to the medical community extending beyond academia is evidence as your role as a past President Foxy, and this leadership position and a subsequent lifetime achievement award is a contribution to the subject of organization in 2022. So overall, sir, there is so many numerous honors, experience, and so many things. But the most important, which I like to say, sir, be my friend and be my mentor all my life. So welcome you today for the Tuesday Tea Time. And our topic is basically the use and the misuse of low molecular weight heparin in cases of recurrent pregnancy loss. So it's a simple dialogue between you and me, sir. And you can start with some opening remarks which you feel like, and we can start asking some questions which is relevant to this subject. And the answers should be as usual. You are the master of anything. We'll try to finish it in 30 minutes. Thank you so much. So welcome.
Thank you very much.
Yes, sir.
No words to thank you. I feel very touched when I am honored. It is your greatness. It reflects upon you people, not me. Thank you. A very, very small man coming from a small mid-sized city of Baroda, and you people took me to these heights, encouraged me and made me do so much original work. Thank you. When a discussion goes to recurrent pregnancy loss and its areas where we can do something, I am reminded of one of my very early papers, which I had sent to Journal of ONG of India. In that time, the late Dr. R.D. Pandit was the editor, and I had written the data on based on 2 consecutive pregnancy losses. At that time, the convention was 3 or more than 3 consecutive pregnancy losses. And he returned the paper, not rejected it as sometimes very irrationally Jogi does it. But that is okay. That is the editor's business, none of my business. But this is a complaint coming. But that is okay, none of my business. I am not in it. But sir returned it back with a remark that, Pankaj, if we will put it to 2 consecutive pregnancy losses, will it not make an over-diagnosis and over-treatment of the condition?
Yes.
And I supported it with evidence to show that no, sir, that fear is unfounded. And subsequently now, after 30 years, it is a reality that the definition accepted is 2 or more than 2 consecutive pregnancy losses. That is how we will set the ball.
Yes, yes, absolutely.
And the area where we can really do something about it, besides some anatomical causes, are immunological causes. And when we started our journey around 3-4 years after this happening, where we started working on heparin, I didn't have the least idea that is where I lacked experience. I'm really not very happy about it, that when I introduced heparin, it took off so much in the country that I never knew that I would have to, then after a day will come where I will have to concentrate on misuse of heparin rather than use of heparin. Good that you have brought in this topic, and it will form a nice capsule which I can take it to my YouTube channel also, where it will continue to support our colleagues for a long time.
So almost you have talked about what recurrent pregnancy loss. So many, I think the most of the audience are there which love to read your books, and you have revolutionized the recurrent pregnancy loss in such a manner that when we start diagnosing about the patient, or when we say that this patient is a recurrent pregnancy loss, you are the master. So, sir, will you like to say something extra about the definition, or is it okay so that we can start with the low molecular weight heparin?
Okay.
Anything?
Okay.
Yes.
Okay. Beautiful. This is a definition most popular. However, I would like to bring to the notice, revise now. I am sure many of you know that recurrent pregnancy loss of immunological type is a reflection of obstetric vasculopathies. Therefore, even if she escapes from recurrent pregnancy loss and the pregnancy continues, she can still have a preeclampsia remote from term, she can still have a stillbirth, she can still have a preterm labor, she can still have an accidental hemorrhage. So what appears as a recurrent pregnancy loss today may be a reflection of a greater malady in the times to come.
Yes, correct. So, sir, now we'll start with it. That the way you have defined it, the way, I think the simplified way, the putting it. But now what is, how, as you have already started to talk about the low molecular weight heparin, but just to tell everyone, sir, how does it work in pregnancy? That's a very simple question probably, but it is needed over here, sir. How it
is it really simple?
No, it's not simple, but you are going to make it simple.
It took me 10 years to understand how it acts. There are 2 processes through which it acts. For you, it is simple and anticoagulant. Fine.
Yes.
But we know it is an anticoagulant. But what it does, as an anticoagulant, it only paralyzes the platelet action.
Correct.
Now, the platelets, thus rendered incompetent, the blood continues to flow with relative ease through the reduced caliber of blood vessels in the feto-maternal interface.
Yes.
As a result of this flowing, the blood doesn't stagnate, and anywhere there is a stagnation, blood, milk, money, knowledge, if there is a stagnation, they start stinking. So if blood stagnates there, then there is a danger of reperfusion damage, which subsequently occurs, and free radicals go flying into the circulation and create their problems. This is one mechanism of action. A joint mechanism of action is concurrently that it blunts the process of activation of platelets. So the platelets are not only are rendered because of cyclooxygenase enzyme getting paralyzed, they just are failed to activate. So platelets are as if they are dead bodies there in this matter, and that's how it keeps the in clinical practice, it keeps the blood flowing, and that is very important. That is most important.
Yes, sir. Means that inhibiting the activity of certain clotting factors in the blood. and
Basically
preventing the
platelets.
formation of blood clots. Am I right?
Yeah, and stagnation.
And
the
the
stagnation is
stagnation.
where the free radicals easily the very low density lipoproteins they sink, and there they get denatured. They get readied in the terrorist activities as it occurs at the line of control, and then they are pumped into India and they create a havoc. That is prevented, and blood continues to flow. Therefore, there is no training of these terrorists. They don't come into circulation.
Correct. So, sir, but the worst problem, the discussion is basically how badly this molecule is being used and how wisely this medical is being used. So, what are the few indications which you say? Yes, Kawita, these are the indications we need to give the low molecular weight heparin. And this, why we are giving is another big thing. So, sir, indications we need a specific indication that this is the time that we should give it.
The only indication, wide indication, but a widespread its prevalence. The only indication is immunological recurrent pregnancy loss only. Now, how will you clinically identify? I have my videos on my YouTube channel, but I will repeat it here. These are essentially late first trimester and second trimester missed abortions.
Yes.
Missed miscarriage. Then no other early losses are not immunological.
Yes.
And live abortions are not immunological. Please. It cannot be.
Yes.
However, there might be a clue for those who are using, and that is where, if you subsequently ask me, there is one indication where you can use heparin at the first go. Okay, and that is if there is a history of a preeclampsia remote from term or an unexplained IUGR only. Then also this could be a vasculopathy. And if you find reasons to believe, then people can start. However, this got misconstrued, and once if you stick to this, to your answer that how much it is misused. Yesterday, today only I have discharged a patient. Previous cesarean section got transferred to some other city, came back for delivery with us. We sectioned her just because she had some recurrent missed abortions. She had recurrent abortions, not missed abortions. Heparin was straightway started. Now, what is more important is that it was started at 20 weeks.
Yes.
At 20 weeks. That is all a misuse. After 12 weeks, this drug does not act. Even aspirin also does not act. You are too late. You are too late. Therefore, these are all what you can call a bouquet of misusing condition. If you actually correctly use it, then the use of low molecular of heparin itself can come down by 16%, 16 times. It can become 1/6 of what actually it is used. Everyone is using it. IVF is used without any. I was conducting a panel discussion with Dr. Duru Shah on recurrent implantation failure in Mumbai, and there also they have just without any reason, heparin, and they come out with fanciful explanations, and I just keep on smiling. That what can I do about it? But then be very careful. This is more misused than used.
So the message is very simple. It should be started as early as 12, before almost 12 weeks.
As soon as you see the FHS.
Yeah, it's the pregnancy before 12 weeks. And it should be the immunological pregnancy loss is one of the reasons. And if there is already the live fetus is there 12 weeks, which you said in those cases, if there is any reason for the immunological things, the low molecular.
Immunological, yes. If there is a vasculopathy in the offing, yes.
And the recurrent pregnancy loss is because of it. So that's another important point. So, sir, the people are using it so much and doing so many things. Don't you think there is so much risk of using it and so much? What is the exact benefits of using it, basically?
The dose in which we are giving, there is no life-threatening risk. Remember, we are using it. We all know if it is low molecular weight heparin, then we are giving 40 international rates. if it is the regular heparin or unfractionated, we use 5,000 international units per day. This is a prophylactic dose. Please remember. Therefore, there is no life-threatening complication. The only problem which can occur is a skin reaction to the injection, which can occur and which can be handled very well by local agents or even ice, and so many surfaces you can give. Many patients give on the same surface. There are so many surfaces which can be given, and then it can be very well handled. It has no substantial impact on, however, on birth weight, on pulling pregnancies beyond 37 weeks. It will come around 37. Does not have any much effect on bleeding episodes or anything. No, it doesn't. So please don't worry about that. By and large, it's quite a safe drug, and the local reactions, yes, they will complain to you.
So it's a safe when it is really needed. Am I right?
Yes, it is safe in the doses in which you use. In the doses in which we recommend its use.
Yeah. So it's basically when it is used, right? So you already talked about what is the optimal dosage we are talking about when preventing the recurrent pregnancy loss, as you have talked about the fractionized and non-fractionized, both the things. Am I right, sir? Anything you want to add about any optimal dosage? And important question is, how should and how long it should be given? Because I have seen prescriptions of a variety of people. Once a week, I was surprised. Twice a week, that was also surprised. I'm not putting in a controversy of anything, but I'm just asking you. And once started, they can stop it anytime. And if not started, they can start at any time also. They started it in a 21 weeks and not then. So that's a very important. The way to start it is very, very important. And to stop it and when to stop it is also very important. And what should be the optimal dose of the heparin?
In a known case, even both autoimmune, not only antiphospholipid, even alloimmune losses, and that is essentially history based. So therefore, this is one condition where proper history will be a must. And I told you, recurrent pregnancy losses, 2 or more than 2, late first trimester, missed abortions, or late first trimester and second trimester.
Correct.
Now, besides that, other obstetric vasculopathies, which I have told you, which are immunological basis. However, I would like to now indulge for about 5 minutes on the 2 heparins. Which heparin? Low molecular weight or our unfractionated? The crisp answer is doesn't matter. Correctly indicated case, heparin will help. Which heparin doesn't matter. There are 2 types we all know. The low molecular weight heparin is much more costly than regular heparin. The total cost of regular heparin will come around 4,000 to 6,000 rupees by the end of pregnancy if you follow the regular protocol. And this might go up to somewhere around 40,000 to 50,000 rupees. So if cost matters, then low molecular weight heparin does not score over. In somewhere around 2021, one paper has come in the book of lupus, in a textbook which was quoted in a very famous journal which covers lupus. And there they have said that regular unfractionated heparin gives better results. However, for us as clinicians, doesn't matter. Previously, till somewhere around 2009-10, there was a trend that you have to get the PT, APTT done for bleeding diathesis if you are giving a regular heparin. But this has been also subsequently proved that no, in the doses in which you give, like low molecular weight heparin, there is no need of getting this test done. So then the topic boils down to that if the cost matters, then you can consider heparin subcutaneously, regular, unfractionated. That is the clear message. Low molecular weight heparin 40 milligrams daily and unfractionated heparin 5,000 international units daily. However, please, a brilliant person like you conducting this panel discussion, therefore I am attracted to put in a small rider.
Yeah.
When you are using heparin and aspirin-heparin combination, you are not treating the cause.
Yes.
Remember, you are treating the effect.
Yes.
Immunological cause treatment is still eluding us safety for pregnancy.
Yes.
In such a situation, there will be there will be cases where your treatment will fail. Yes, it can fail because the cause is still there. Now, in such a situation,
Yeah.
if there is a major failure, you will have to have courage of confidence, and you will have to double the dose. In that case, heparin will be 10,000 international units daily, twice a day, and that will be a therapeutic dose where PT, APTT every 15 days has to be mentioned.
Yeah.
I'm not talking of bleeding time, clotting time, that is
gone.
PT, APTT.
Yeah.
Second, if it is a low molecular weight heparin, then that comes to 80 milligrams. Sorry, initially I said units. 80 milligrams daily.
Yeah.
That will be the change which will be required. Sometimes I'm asked this: can low molecular weight heparin be used alone, or does it require combination?
Yeah.
All the data which we have produced and throughout the world, by and large, are in aspirin heparin combination, and therefore aspirin has to be started. Best results 3 months before at least the conception.
Correct.
Not heparin. Aspirin you start, let her conceive, don't start aspirin. 1.2 milligram per kilogram is the dose. And then, as soon as you see efficacy, start heparin. In a correctly indicated case, that's the guideline. That is how you administer heparin.
Correct. So in a small words, then if you use a low molecular weight heparin or unfractional heparin, almost you mean they are almost similar?
Oh, absolutely.
Absolutely similar. Except a few points regarding the monitoring. Cost. Monitoring is also important, sir.
Monitoring is that if you give a therapeutic dose.
Yeah, and cost is a very, very important point.
Yes.
And both the tests, as you have said about the partial thromboplastin time and the regulations, but I think and in a combination, when to be given, the aspirin should be started and should be followed. It's a really good thing. And reversibility of the drug with low molecular weight heparin or with the unfractional
72 hours.
Almost similar. Am I right?
72 hours.
Yeah, 72.
Yeah, I'm taking you to your physiology lecture.
Yeah. So
okay, but the life of platelet, life of platelet is 72 hours.
Yeah, so that
within 72 hours, that platelet which you have deactivated or you have paralyzed its cyclooxygenase, the entire bunch will go out.
Yeah.
And a new bunch will come. So it will be reversed in 72 hours. Remember, this heparin doesn't cross the placenta. Its molecular weight is much higher than that which the placenta permits. And therefore, don't worry, it will not cross the placenta. No problem with the baby.
Correct. So, and in a combination, you said that we can see the low dose of aspirin with a weight and everything.
Yes.
And they also further reduce all the pregnancy complication. And the best part, which I said, that the immunological, we are just treating is a effect, not the cause of the.
Yes.
Yeah, that's another very, very important.
You can fail, and so don't be disheartened. See, if I failed and then she went to Kawita madam, and Kawita madam, she became successful, that is okay. Let us, one thing which you did hint at was the success rate. How much? Madam, one thing very important for people like us, who are working in this field, is humility. Very important. And these things have made me very humble. Without any treatment, also a case of recurrent pregnancy loss, without not doing anything, has a chance of a spontaneous resolution of 70%. 70. तो मैं क्या कर रहा हूं उधर? I have to give a significantly better outcome. And with aspirin, heparin in a correctly indicated cases, this can go up to 96%. 96%. But 4% of the cases you can still fail. Be humble. Kawita madam can succeed. I might fail. That is okay. Because we were treating the cause, or we are treating the effect and not the cause. Fine. No problem.
Absolutely. And that's why in data also we say that the patient of recurrent pregnancy loss, as you have suggested, if you can have a successful pregnancy and one cannot make, maybe every fourth chance about the immunological pregnancy, they say there are chances of, I think you are the right person to talk about it.
Spontaneous resolution.
Yeah, spontaneous resolution.
Gives you humility.
Yeah.
हम अपने आप को बहुत बड़ा समझने लगते हैं.
No, it
और
happens.
फिर पता चलता है कि there is some puppeteer.
Yeah.
Who is playing the whole thing?
Yeah.
So please.
Even
Carl Sagan and Albert Einstein believed in God. Though they were great scientists.
Correct. He's playing the orchestra.
Yeah, he is the puppeteer.
Yeah. Yes. So, sir, so in a other nutshell, we'd like to know, sir, in which contraindications, so that we know this is the case of recurrent pregnancy loss and all, but we need to know that these are the few contraindications where we should not use this. Yeah.
A known case with bleeding diathesis.
Yeah.
Or a cardiovascular disease. They somehow they are telling this relative contraindication. Previous thromboembolic phenomena, previous bleeding because of thrombopenic phenomena, smoking they are telling, uncontrolled diabetes mellitus.
Yeah.
Morbid obesity is now a controversial thing because we are in mothers with morbid obesity. We have to give heparin because of the fear of deep vein thrombosis after the cesarean section if she requires. If she doesn't start moving early, we have lots of Western data where prophylactically they give. So this becomes a relative contraindication, and I would not like to give much credence. However, any presence of any contraindication to anticoagulant therapy, which is very less, will be the only anticoagulant, will be the only contraindication to this.
Correct. So you means another important latest people are gestosis people and all this, but uncontrolled hypertension, they are worried about giving this liver disorder.
I am not.
Yeah, we are not.
I am not. Don't be afraid of it. Yeah, there is not enough data. Yes, I am aware of it. Because I get emails on this, but at this stage I am not.
Yeah, liver impairment is there, liver dysfunction is there. So, but the important point is the right monitoring is needed. Am I right, sir?
Yes, liver problems, chance of pregnancy will be less, but jaundice, in presence of jaundice, a little tough.
I think who is going to? Yeah, absolutely.
Absolutely. Liver taking the predominance.
Yeah.
So she will not be having a liver problem all through. Yes, if it is a liver transplanted patient. Now there are very few data liver transplanted patient who will be on immunosuppressants.
I know how
and going in for pregnancy. These are
something very unusual, uncommon situations.
My teacher used to tell in medical college that Department of Surgery, when you think of rare things, you are rarely correct.
I know. No, I'm just, I think I am completing the problem but it is not needed. Sir, we can talk about a little side effects which people have during this is also important.
I will comment, yes. You can give me the side effect because I predominantly find the subcutaneous bleed or the itching and the skin discoloration. That is the biggest one I find.
Yeah, that's fine. And sir, any follow-up needed? Over there, which is the final point, I think.
The recommendation line is start as soon as you pick up the FHS. Can you see? Can you hear? Hello?
Yes, sir. We are there.
Can you hear?
Yes, sir. Yes, sir.
Okay. Shall I continue? Because Kawita is frozen.
Sir, I am there.
Okay.
Yeah.
Kawita's image is frozen. Yeah, and I can't believe that I am so handsome that Kawita will freeze at this stage of life. But madam, okay, brilliant. Why I love this question. The current recommendation guideline is this: as soon as pregnancy is diagnosed, up to 36 weeks, stop at 36, induce at 37.
Yeah.
However, nothing is. In obstetrics or in science, there is nothing which is static. There is always dynamism. Madam, we have color Dopplers with us now.
Yeah.
Okay. What we do, and we have published data on this, we focus at 12 to 14 weeks on the uterine arteries. We will surely find a diastolic notch. At 20 weeks now, we are giving, because it's an obstetric vasculopathy, hypertensive disorder, whatever, there will be, even physiologically, there will be a diastolic notch. Okay, we can measure the diastolic notch and it has got lots of clinical implications. We will not touch this, it can become a discussion. But in next 2 or 3 minutes, I will, because we are already 30 minutes past, I can tell one thing, that if the diastolic notch has disappeared at 20 weeks in both the uterine arteries, one, and second, if the pulsatility index in both the uterine arteries have gone down to 1 or less than 1, have the courage. The obstetric vasculopathy has been tamed, where the maternal system has tamed the immunological response, and in such a situation, your treating the effect is superfluous. You can stop heparin.
Yes.
Once again, this is more in research papers, quite a few research papers, but you have the color Doppler, look at it, and if you are not doing second trimester scan, then your sonologist please insist that, sir, we want a color Doppler where they please tell about whether diastolic notch is present or not in both uterine arteries, and whether PI has, what is the PPI they will tell. If it is less than 1, then you have the courage to stop heparin. You can stop heparin nearly 15 to 16 weeks before, but that will be only around 18 to 25% cases, not much. Our data shows around 21.6% cases, but for those 1 in 5 cases, they were comfortable much before, and adverse outcomes did not increase.
Yes. So it's very important, sir. It means
once again, Kawita is frozen.
No, I am frozen. I am there, sir. Hello.
Hello.
Hello. I am there. I am very much there, sir.
Yeah, आपकी image photos freeze हो जाती. Okay, fine.
I am very much there, sir. Very much there. So, sir, in a concluding point that you have suggested when to stop, when not to stop, what is the best use of it? And I think the message, take-home message for everyone, the use cautiously about the drug, use properly, use judiciously, and always think that you are using in your own relatives, your own family, whenever, whatever drug. Am I frozen? No. I'm there. Yes, sir. So thank you so much, sir, for being with us today. And our goal is very simple.
And keep reading about it.
Yeah. Keep updating, keep reading all the time. Hello.
Yes.
Yeah. Thank you so much, Jyoti. Am I audible, Jyoti?
Yes, you are audible.
Yeah.
But your screen freezes.
Oh my God, sorry, I'm sorry for that. So these are the benefits of joining the Tuesday tea time, because we get the crisp knowledge about various subjects. We learn from leaders, especially the leader and experts like Pankaj Desai today. I'm really thankful to him. And we can expand our network and connected by like-minded individuals. Thank you so much, those who have joined today. And we can be updated with the latest trends and insights in OBGYN. And this is basically the perspective and experience in the other. So thank you so much, sir, for being with me today. I am always blessed. Be my mentor, be my teacher, be everything.
God bless you.
Thank you.